Hi guys, so a quick short video on diagnosis and imaging. Recently I had a number of patients who I've been consulting with, and because of the longevity of their symptoms, this in the primary care setting, my role in the general practice that I've been on, because of the longevity of the symptoms, they feel that they would benefit from x-rays. So I'm going to use that later on. However, just to start with, I'm going to help you to understand what the diagnostic process is. So diagnosis is an art in itself. 80 to 90% of our diagnosis is actually based on the clinical symptoms, the case history that we take, and all the information that we glean from what you have said. So what you'll always notice is you'll ask the practitioner or otherwise a competent practitioner to say, well, tell me a little bit about what's going on. And that is what we call the golden minute. It's the opportunity for you to tell us basically everything that is going on with regards to your symptoms and your issues. So we remove all the waffle that is in this and only take away from here the clinically relevant information. And what we're looking for here are leads. Rather like a detective follows leads in terms of their work. So this is no different. We're basically doing a bit of detective work in terms of the body. So the leads that you then provide, we will follow those, and we will then in return ask you a set of questions. Each set of questions is basically tailored around the lead that we've got. So these leads essentially are differential diagnoses that we've got in our mind based on what you said, that we're thinking what this possibly could be. Now we have to then confirm or otherwise try and get as clear, as accurate as possible a diagnosis. So then we ask you questions in and around that area. So then you'll say okay, yes or no to certain questions, and it'll be a matter of actually this lead was useless, it's a dead end, we want to the next one, and in doing so we inform the diagnostic process. Once we've got that diagnosis, that's when the investigations come into place, so the management, which includes your investigations. So what do we do here? Once you've got a lead, your diagnosis is virtually made, and as long as you've followed that lead properly. What we've got to be careful of here is sometimes you can have two leads both showing positive signs, and so you could have a superimposition or two things going on at the same time simultaneously. So what we've got to do is then inform the management process, and on occasions it's not very clear as to what this is, and so what we do then is we just carry out a number of investigations following two or three different leads, and to try and understand which of the differential diagnoses it is that we're suspecting is actually going on. So differential diagnosis is all the number of contending hypotheses of the suspicions that are which we considered based on your presentation. So then the investigations, these may include bloods, might include urinalysis in a typical primary care setting, a swab for example, and that the urine and the swabs may well actually be sent off for to the micro labs for cultural sensitivity to try and identify the pathogens at fault. Now, the more important thing I want to get to is the actual scans and images. So like I said on the outset, a number of patients have recently been asking for x-rays. Now, and quite understandable because there's no resolution to their symptoms despite the rather conservative management that they might have to have employed, including the use of heat and ice and rest, and then where necessary topical use of steroid, NSAIDs, gels, analgesics, and so on and so forth. So, and the point I want to make here is imaging only confirms the diagnosis, it doesn't make the diagnosis. The diagnosis is virtually made on the base of the actual consultation that we had and the conversations that we've had in a clinical setting. So the diagnosis in the vast majority of cases, clinical diagnosis, the imaging and other investigation that just confirm that. An X-ray, for example, is simply going to show us more often than not bony injury. Yes, okay, I appreciate it will give us more information than simply a fracture. The likes of bone density can be seen, massive fluid or swellings can be seen in the area, amongst other lytic lesions, so pepper pot lesions, for example, hair on end appearance, etc., in thalassemias, or so rather in multiple myeloma or thalassemia respectively. So these are separate findings, but more importantly in the context of primary care setting or immediate concerns. an X-ray will not show bone. An X-ray will not show ligaments, tendons, bursae, fat pads, skin, or any situation like that. So bones, X-rays are confined to bones. So if you then present to me with a set of symptoms that would indicate a soft tissue injury or lesion, there is absolutely no reason for me to send you for an X-ray. All I'm going to be doing in that situation, were I to honour that request, is purely and simply palming you off or otherwise, sending you and having you exposed unnecessarily to some radiation, which in its entirety is unsafe in large doses. So there's no reason for that in that situation. MR scans, on the other hand, will show absolutely everything from fluid to air to ligaments, tendons, bones, bursae, literally absolutely everything. So MR scans are the ultimate, but again, that comes with the masses and large amounts of radiation. Shoulder issues I see a lot of, and in shoulder issues, the best investigation in my point of view, or the most clinically valuable investigation here, is actually an ultrasound scan. So very little in way of radiation, in fact no radiation for that matter, and clinically very valuable to be able to see bursae and ligaments and tendons and bones. So you can actually see a fair few things on an ultrasound scan. So I hope that kind of helps you understand, when we are considering imaging, why we consider certain types of imaging over others, and the fact that most important take-home message from this clip is imaging is not used to make a diagnosis, it's actually used to confirm a diagnosis in the vast majority of cases, and in the vast majority of clinical presentations, the diagnosis is made by a competent clinical case history. Thank you for watching.